Okay. Láti lò sí kúrò náà.
Hello. See, I'm come.
Yeah, I think the secretariat is set for us now. So in the next 1 minute, we just kickstart.
I'm gonna be that one. I'm gonna be that one. That one.
Hello,
Three.
Lagos State coordinator and convener, please, can you tell the secretary to put everybody on mute?
Okay. Please, secretariat, can you please
mute themselves?
So, Rotary can please take over in the next 1 minute. But before it does that, I want to specially welcome distinguished and respected Rotary leaders international on this platform this evening. The DG is not here at the moment. So permit to start therefore from a national chairman of RMCH in the person of Rotarian Professor Emmanuel Fadeju. You are most welcome, sir. And I also have here my respected Parish Governor, District 910, and the Southwest Membership Coordinator in the person of Parish Governor, Rotarian Lawson. You are most welcome. And we have other respected Rotarian leaders here, starting from some of the coordinators for the states and RMCH. We have a few of them here as well. That note, we have to hand over to Rotarian to please continue with the program.
Thank you very much. You are all welcome to the 9111 Disease Prevention and Treatment Committee webinar being held in partnership with Women in Rotary, RMCH, Maternal and Child Health Committee of the 9111 and Rotary Club of Ewutu, 9111. At this junction, I would like to call on the DG to open the floor, but right away, he is not here. I'm talking about in person of the DG, Lieutenant Prince Henry Akinyele. Since he's not here yet, we can move forward. May I request that the convener, the chairman of the 9111 Disease Prevention and Treatment Committee, to please give us the opening remark so we can start the program we can push the program in earnest because we are about 5 minutes behind, having done the due recognition. Thank you very much.
Hello, did you hear me at all?
Mute. I think you were muted.
Okay. I just requested that Rotary should please kindly allow me to request that this chair coordinator Southwest in the person of Rotary and Patrick Governor Maternal Lawson should please kindly read our opening remark on behalf of committee. I give that honor to her. Opening remark.
Okay. The convener, please, can you come again?
Yes, I just requested that you have the honor of giving the opening remarks on behalf of the committee, disease prevention and treatment, and all its partners. A brief opening remark. I give that to them.
Okay, thank you for the honor, the privilege to give the opening remarks. Let me recognize our district governor, Roteran area Kenyele. I know is very, very held up somewhere. Country director and national coordinator, reproductive, maternal and child health action group, Nigeria, Professor Adedola Kolufadeju. You are recognized. Of course, the convener of the disease prevention and treatment webinar, the district chair, and the Lagos state coordinator and membership chair for RMCH, PAG, Dr. Olufemi Oloyede. Rotary leaders are present. I'm delighted to do this on behalf of the committee. Let me first of all acknowledge and congratulate the Lagos State Coordinator for RMCH, PAG Oloyede, for yet another program, which makes it 2-in-1 program today. Earlier today, we had a very, very laudable project done in partnership, done by a productive maternal and child health action group, Lagos, to be precise, Lagos State Chapter, in collaboration with the Club of Ewututu, Rotary E-Club of Maryland, and there are also some other stakeholders. And the program, which was announced earlier and publicized, was held today, this morning, to train traditional birth attendants. And I dare say that it's a pity that Farijo couldn't be part of this program, but we'll have been very proud that Southwest is moving. And we are just started. This is the pioneer edition that we just held. And we now follow it up with what we are having this evening, which is now a district program under the leadership of PAG Olufemi Oloyede. So congratulations to District 9111, being the district that is spearheading a kind of program like this in a month that's the executive in Rotary as Maternal and Child Health Month. So on that note, I welcome everyone here present, and I'm sure that we shall be delighted you are part of it. Let us invite those who are not here to join the webinar. It's an online program. I can't see any woman missing this. But what I learned this morning, I tell you, they are much more than what I thought I would have gained from that particular program. So let's call those who are out there to please join us. So thank you once again, and I welcome everybody. Thank you.
Thank you very much, our own Koshelori in Rotary, and we appreciate you. Can we please go ahead and ask the chairman of the Disease Prevention and the Treatment Committee to give us facts on why women die in pregnancy and for us to understand the issue more, May I call on Dr. Femi Loede, a past assistant governor, to throw more light on this. Thank you very much. Mr. Loede, you have the floor. Mr. Loede, you have the floor. Mr. Loede, you have the floor.
I think I've muted everybody. PPL, so please check. You are even muted, so also you are muted.
Okay, I think it's better now. Yeah, good. I'm unmuted now.
Yes, you are okay. You are
Okay,
good to go.
okay. Yeah, thank you so much. I apologize again for that little itch. I was trying to come on board, but I found myself completely cut off. So very briefly, I will kickstart the discussion this evening by quickly allowing us to look at the subject of maternal death in Nigeria, and the matters arising, and the reason why we must call for action. Let me first let us know that most of the issues, health issues discussed all over the world, actually has to do more with maternal health. And the world has about 8 billion people, represented by males and females in equal proportion. We begin to realize that while males are not as frequently as females confronted with disorders, females are mainly at risk for 3 major reasons. The females are those who preserve the families, they make economic contributions, and they perpetuate human race in form of reproduction. And who are these females you are talking about? Number one, adolescents, pregnant women, lactating mothers, and postmenopausal women. Of all of these, the one that concerns us this evening will be those who are pregnant and have cause to deliver. I'm sure if I ask those on this platform this evening, if they've not heard or seen or witnessed, experienced the maternal death before, or read about it, there will hardly be anyone here. So the issue therefore is, why should our women die because they are carrying out their natural, God-given responsibilities? If you look at the statistics all over the world, as we speak today, Nigeria still ranks as #1 country with the highest number of women dying because they are pregnant or because they are delivering. And yet, it is in this country that we have a lot of manpower that we export all over the world, doing greatly and reducing maternal morbidity and mortality in different parts of the world. Yet, at home here, we have a lot of our women, mothers, children, sisters dying. And for each one that dies, the effect is not limited to the individual. It has great influence on the family, on the community, on the nation at large. When we realize that the family is the nucleus of the nation, relies more on women rather than men. And that is why we must begin to pay attention to the fact that we do so well in every clime, yet we still have our women dying. I take us very briefly through the statistics. If you get to the UK, but before the statistics, let me quickly remind us that when we talk of women dying, maternal death, what we are saying is this: that a woman dies because she's pregnant, or within the first 6 weeks of pregnancy, because of that pregnancy itself, or something close related to it, is what we refer to as maternal death. And then, if you look at the world statistics, all over the world, start with UK, averagely 11.4 women out of 100,000 deliveries would die. That is, if 100,000 women goes into labor, it goes to pregnancy today, delivers today, only 11 of them will die. If you get to the United States, 19 out of 100,000 women that get pregnant and delivers will die. Those are nearly single digits. The same thing in Greece, which is even much better. 8 out of 100,000 women delivering will die. Even close here, United Arab Emirates, only 8 will die. But let's come here now to Africa. Let's start with Egypt. In Egypt, that has the brightest figure in the continent, 30 women would die because they are pregnant or because they are delivering. South Africa, that prides itself as the most civilized in Africa, 100 women will die because they are pregnant or because they've gone to deliver. And that is probably the best we can refer to. But let's now look again at what happens globally. Every day, 810 women die because they are pregnant or they are in labor. 810 is a colossal figure. Is sometimes more than the number of a large aircraft from here to New York and other place. About 3. If you say an average of 300 passengers in a flight, 350, it means you're having 3 flights crashing every day all over the world because women are carrying pregnancy or delivery, and yet they remain unsound. And why is that so? Because most of these deaths, about 95% of them, occurs actually in low and middle income countries. And so any tragedy, therefore, that involves from those parts of the world remains relatively unsung, remain unnoticed. But to us, we can no longer pretend that most of our women, over 90% of those that die globally every day, are actually our women from Africa, Sub-Saharan Africa, South and Asia. And so the strategy we have today is such that even though we have 3 aircraft crashing filled with women, pregnant women, the bulk of them, 9 out of 10 that dies, will either be from Sub-Saharan Africa or Southern Asia. And so if nobody talks about it, we must begin to talk about it because these are our women. But let's go a step further and look at what we have in this country that we pride ourselves as the largest Black population in the whole world. Recall I mentioned that averagely about 10, 14 women would die in the United Kingdom, in the United States, because they are pregnant. About 100 will die in South Africa. But look at Nigeria. Over 1,000 women would die because they are pregnant or they want to deliver. That is completely unacceptable. And that is one of the reasons why Rotary International has looked at maternal mortality as a big challenge. Fortunately, we are almost done with polio. We are so much interested in malaria being a major issue. But the next issue that takes priority after that will probably be maternal death. And it is so important that we look at it in Nigeria because out of these maternal deaths all over the world, 20% of them occurs amongst Nigerians. Let me put that properly. Of the 810 men that dies every day, 145 will be from this country. 145 is the size of an aircraft from here to Abuja. So it means we have one aircraft crashing every day containing women that are pregnant. Again, most of them dies unnoticed simply because they are peasants. They don't belong to the high economic class. But as Rotarians, as Rotarians must begin to look at this, that we're having one aircraft crash in this country every day because they are pregnant. But let's not point it down to Lagos State, where we are at the moment. If the national figure is over 1,000, which is the highest all over the world, Lagos have a mortality rate of over 500. That again is far more than what we have in South Africa or most other African countries. So it means if Lagos is one of the best states in the country that pays attention to mortality, we must see ourselves when we begin to look at these figures that as good as we are, as excellent as we are still a very far cry from what it should be. The question then is, why do these women die in childbirth? There are several ways to look at this, but I'll just discuss three very briefly because of time. The first one is to say most of our women that dies are women that goes into pregnancy and delivery when they should not go into it. Those are the extremes of age. Very young girl that is not up to the age that she should be reproducing gets pregnant. They don't know their left from right, and most of times end up dying. Long interpregnancy intervals. You deliver now, within the next 1 year, another pregnancy, when the woman has not recovered completely from the effect of the last pregnancy. She's at a higher risk of meeting tragedy. The same thing with women who have delivered over a long period of time, 8 years, 9 years, 10 years. Such pregnancy becomes like a completely new pregnancy. And so these two groups of women are women that are not competent to be pregnant, but they are pregnant. Again, you might be talking of failure of contraception in some of these cases. The next group would be availability, accessibility, and utilization of medical services, which is really poor in this part of the world compared with other clients. Now, let us look at it. Most of our facilities, especially in rural areas, are staffed very poorly because every medical staff competent want to work in the cities. Most of them do not have the standard facilities that they should be equipped with to take care of pregnant women. Even beyond that, the women sometimes, when they are pregnant at home, find it completely difficult to get to the facilities because of transition delays, cultural influences. They must go for their husbands. Religion prohibits that they must take certain decisions by themselves without getting the consent of the husband, even when it has to do with their own health. Educational setbacks. These are things that affect accessibility and utilization of medical services. But look at it again. Most of these services, while they are in the urban areas, unfortunately, in the rural areas where the bulk of deliveries takes place, they are hardly available. The third group are those we look at, we call medical factors, which is well known to the medical people. Bleeding, especially after delivery, remains a major cause of women dying. But that is for those who get to where they should even deliver. And there are two types of bleeding, really. Bleeding before delivery, bleeding after delivery. The one that is most important is the bleeding after delivery. When the baby would have come out, and then the mother is still on the bed, and she's pouring. And many times this happens in facilities that are either ill-equipped, staff-wise, or equipment-wise. Or sometimes in women that are not competent to even get pregnant. She gets pregnant within a short period of time, she's still having shortage of blood, and cannot cope with every little bleeding in that pregnancy. And the other group will be hypertension, those with high blood pressure. And this is becoming a major issue in this all over the world. That we now have many more women dying because they have what we call high blood pressure in pregnancy. And this is something that can be easily picked up and managed or prevented. And the last group are those that have infection or sepsis. Again, we thank God with the huge antibiotics all over the world now available. This is becoming less prevalent. So, in a nutshell, therefore, women die because they are not even adequately prepared to get pregnant, or when they get pregnant, they are constrained from accessing or utilizing medical services, whatever reasons. And sometimes when they do, they have medical factors that prevent them from to die. Now, just a minute, I understand I'm having echoes. Let me just quickly close down. Hello? Hello? So I think I'm still audible now.
Very.
Now, the next slide is now clearly showing what is Rotary goals for maternal and child health, maternal health in particular. The first thing is that Rotary believes that we must reduce maternal mortality and morbidity drastically. And that's why we've dedicated a whole month to this subject, that I should keep talking about maternal mortality and morbidity as well as child. But this conversation probably goes on even after this period, but at least that an entity devotes a whole month speaks volume about the importance attached to it. We must also improve access to essential medical services and must train community leaders and healthcare providers involved in maternal and child health. That is the goal of Rotary for maternal and child health, amongst other goals. Again, there is something called Sustainable Development Goals, which clearly emphasize the fact that we must reduce maternal mortality by 2030 to less than 70 per 100,000 deliveries, and that no country must have a maternal mortality ratio that is more than 2 times the global average. As a country, we have failed completely in these particular goals. What therefore will be the recommendations to meet up with this? Number one, we must begin to educate the community on the importance of skilled deliveries. We must be able to make available and accessible and affordable emergency obstetric care in health facilities, both rural and urban. We must look very carefully and diligently at contraceptive awareness and uptake. That is very important if we must begin to reduce maternal death in our community. But let me quickly address the issue of the importance Rotary attaches to it by saying that, look, the area of focus number 4 says we must save mothers and child through some of those measures that I've mentioned earlier on. The key fact, as I begin to round up, is the fact that every day, a lot of women begins to die from pregnancies and deliveries, and at every minute, every 1 to 2 minutes, somebody dies somewhere in the whole world. and that the bulk of the 90% are from this part of the world, where there is shortage of skilled health professionals during pregnancy and at deliveries. Some of the efforts that have been put into reducing this particularly came into being from about 1994. And I'm honestly very happy that some of those who partner such efforts are on this platform. In particular, our party governor, Emmanuel Adefolaju Lufadeju is here, Adedola Lufadeju is here, who in collaboration with some of his colleague PDGs at that point in time, as far back as 1995, has realized the importance of bringing maternal death and child death in this country or in third world to a halt. And they've been involved in several initiatives over the years. Some of these would include projects like for child spacing, projects like for child and family health, treatment of adulation of VVF in the northern part of the world, but more importantly, looking at quality assurance and obstetric care, as well as introduction of what we call the MPDSR, which has largely contributed to good reporting to alert us and know what we should do. And more recently, we are talking of the Little Strategic Health, which I'm also privileged to be robustly involved in. These are some of the efforts that Rotary has made through RMCH to be able to bring down maternal mortality in this part of the world. We must begin to bring this down collectively by talking about it first. But at the club level, which is my last slide, how can we support these initiatives? How can we reduce our mothers dying, having established that we have the highest figure all over the world? We must review our project style. Many of our projects in the club are done at urban centers. These are centers that have fairly adequate number of things, equipments that are take care of the women. Unfortunately, these are centers that take care of a very small number of pregnant women. The bulk of them are in the rural areas. We must begin to do maternal and child health programs outside our immediate community if we must make effect. If we want to be serious about it. We don't have to stay in local government next to our house. They have everything. But let us now move to local government, to health centers completely in rural areas to be able to get that impact. Let us also begin to look at those we are training, whether we like it or not. The bulk of those who will handle deliveries, pregnancies, are traditional birth attendants. And that was emphasized very clearly this morning, that we need to pay attention to these people because our women will pay visits to those centers. Where we invest a lot of our project fees, they would have landed in a terrible, complicated situations. So clubs, therefore, must be deliberate about where and how they do projects. We should move away from projects in urban areas to get to maternal health, move to rural areas, pay attention to TBAs as we have decided to start moving forward from this morning. That does not mean we will not do in urban areas, but the bulk of our funds should be in those places. I must begin to follow up our projects because many clubs do projects one-off, never followed up. So if you ask a club, therefore, what impact have made on maternal reduction, maternal death and child death reduction, they probably don't even know because they just donate this, and they move up. They don't keep track. Need assessment, whether it's the global grant or club grant, now becomes very important. Not only in club grant, in global grants, not only in district grant, but even in club projects, we must begin to take need assessment very seriously, especially when it gets to do with maternal and child health. It is only when clubs begin to shift that focus from where we are now to where we should be, which is the rural areas where this man died, that begin to make impact in this particular field. I want to thank you most sincerely for listening to me in the past few minutes, and together we must join and to eliminate preventable maternal and child death in our country and in particular in our district. I thank you so much.
Thank you so much, Dr. Femi. If you can make a quick recap, you've said that Nigeria accounts for 12% of global maternal, neonatal, and stillbirth deaths, with about 145 of our women dying daily due to complication, with only 2% of our births assisted by key personnel. Also, we remain far from the United Nations 2030 goal, ranking third in maternal mortality. It's on this note, I'd like to invite our own questionnaire, who will be speaking to us on reproductive and maternal child health, the RMCH group, the action group, on how we can use membership of RMCH to drive maternal death reduction as projects in Rotary. May I invite our own past district governor, Omotoye Lawson, the ceiling breaker, the RI Assistant Rotary Coordinator for membership for Africa, to please come on board and present us facts on how RMCH can reduce maternal mortality using RMCH membership. Thank you very much.
Thank you very much, the moderator. Well, I have recognized our leaders in the House, but I want to recognize especially my own club president of A Club of Maryland, Jordan Joyce Mary Shejido, and all the members here present. You are most welcome. And of course, the Deputy Disciplinary Facilitator, Peggy Taiwo. I just saw you online. You are highly recognized. Yes, second slide, please. What the topic says is promoting membership of reproductive and maternal health, maternal and child health, RMCH action group to drive projects in maternal and child health. That is what we are talking about, how to promote membership of the action group to drive projects in maternal and child health. Thank you. Second slide, please. Next slide. Next slide. Okay. It's not that I'll be repeating what our first speaker has said, but there is no way I can talk about membership or getting members enlisted if we don't know where we are coming from, where we are, and where we intend to get to. We know especially that the RMC, this action group, is basically to reduce maternal and child mortality rate. If it cannot be brought to zero, at least to reduce it drastically. And why are we Rotarians? Because as Rotarians, we must ensure that we are part of this movement to reduce maternal and child mortality. What is maternal mortality? Just as it has been explained, death of a woman during pregnancy or within 42 days of its end from causes related to pregnancy or its management. It excludes accidental or incidental death, e.g. accident, homicides. We're not talking about such deaths. It occurs during pregnancy, during childbirth, or postpartum. Usually, it's as a result of bleeding after childbirth. Next slide. Now, I'm only going to be precise. It can be as detailed as Dr. Oloyede's own. How we measure it, as it has been said, maternal mortality ratio, with acronym MMR, means deaths per 100,000 live births. This can be an indicator of the general health of the health of the entire population of a place. What is it like? And of course, the quality of health care in a particular place. In 2023, global MMR stood at 197 out of 100,000 births. It came down from what it was in 2000, when it was 328 deaths out of 100,000 live births, which means that there was improvement. And there must be a reason why there was improvement. Because there was an intervention in place. That was why this happened like that. And is that intervention that will continue to keep this mortality rate down. The Sustainable Development Goal, SDG, target by 2030 is to reduce this mortality to 70 per 100,000 live births. And I'm sure it is doable. We can get there. Next slide. Where the need is greatest. Dr. Olóyèdè explained that when you look at the map of the world or different countries in the world, definitely this ratio, the maternal and child death, varies from country to country, from region to region. Over 90% of maternal death occur in low and lower middle income countries. And of course, we all expect Nigeria to be there. In fact, if you continue to look at it, we see where Nigeria placed. Just like our speaker just said, Sub-Saharan Africa account for 70% of global maternal death. Southern Asia, 17% of global maternal death. The 4 top countries in maternal and in MMRs include the following: South Sudan with the highest maternal mortality rate, followed by Chad, followed by Nigeria with 1,047 out of 100,000 live births. And we have 855 in CAR. Next slide. Central African Republic, that's CAR, Central African Republic. World mortality rate data. But these things are not just said. There are data to support it. Research goes on every day. And therefore, where we are is exactly where we see ourselves. Worldwide, maternal maternity ratio, MMR, per 100,000 live births has improved by plus 263 between 1985 and 2023. Because in 1985, we had 460 deaths per 100,000 live births, which reduced to 197 per 100,000 live births in 2023. So we are getting there. It can always be better. Next slide. Causes of these deaths. 1, direct causes: hemorrhage, bleeding, infection, pre-eclampsia or eclampsia. Incidentally, I happen to be a victim of pre-eclampsia. When I was having my first child, nothing happened. I don't think there was no high blood pressure, so I went to labor normally. But at the point in the course of monitoring, I think the blood pressure rose. And before they were doing regular checks, it was at UCH in Ibadan. I discovered the blood pressure was high. And at the point when they discovered that the baby, the fetus, had what we call APGAR score of 9. But that time, when I knew what APGAR score meant, that is how healthy the child will be born. I think the heartbeat or something, it what gives the APGAR score. When it was 9/10, they now decided to go for cesarean section. Now, if it were to be done outside, or if I had gone to a place that is not in the hospital, like with our TBAs, probably it would have led to eclampsia itself, which is fit convulsion, and one could even pass on from there. So there are causes like that. And of course, complications of delivery, like what we had today at the training we had. That depends on where the child is, what else is presenting is the fetus. By the time the fetus has gotten to about the last 2 months, and is now horizontal position, and where will the child come, with what part of the body will the child come out? When the head is not down, and the buttocks is not down. So it becomes difficult for the child to be born. And if it were to be with the TBAs, there's no way they can deliver such a baby. So then we have indirect causes. That if there are things that the mother had earlier: high blood pressure, cardiac disease, HIV, tuberculosis, pneumonia, anemia, stroke, cancer, and other problems Once those causes and their underlying other underlying ailments, then you can find there are indirect causes that can also cause death. And this might not even be known if someone goes to a place where you don't have all the facilities to detect all this. But guess what? Prevention is possible. Next slide. How can we prevent this death? One, you can prevent unintended pregnancies through several means. One, education. Part of the education is what we did this morning. Where people are ignorant, there will be causes of actions or inactions because they are not educated. But when you are educated, you know what you are not to do or what you are supposed to do. What kind of food should I eat during pregnancy? What kind of medicine should I take? What are the medical tests I should do? All these things, they come into play. Then contraception itself. When the person is having about, we already have 5, we're looking for a boy, a girl, something like that. And there is no limit to what, you don't even know how the womb has stretched, uterus to what extent has stretched. And the mother does not know how to use this contraception. And of course, access to quality care. Environment matters. Where does the woman deliver the child? Infection is not what one can joke with. And of course, those who are even attending to these pregnant women in centers outside of hospital, how clean are these? How clean are they? The handlers of these mothers and the babies. Then to ensure care before. I mean, it's not only when the person is now almost due for childbirth that the care should be there. So skilled care is very essential. Next, Roach's intervention. How do we come as Rotarians? Of course, what does our motto say? Service above self. Rotary supports capacity building. Every time, in most times, when you even give water projects in a place, you still have to talk about it. You still have to train the users of the water. How must they still keep the water clean? So there's not you want to give in Rotary that you must not. There must be training part of it incorporated. Then how do you get to the grassroots? How do you empower those at the grassroots to take adequate care of whatever facilities are provided for them? And you know, there can be trainers. I have known it. What I got to know today, or what I've read from favor presentation, I also can go out there and talk to people. I can decide to cut at any gathering and talk to them about ordinarily the dangers of living at home, or not ensuring that you go to either it is TBA or it is hospital, but make sure that you are being attended to in the proper, in a very well managed facility. And of course, we need to partner with action groups. You know, yes, we have reproductive, maternal, and child health action group. There are other action groups that has to do with maintaining our health or preventing diseases. And if you are part of them, you get solutions. I did a project in 2023 for students with hearing impairments at school for this hearing impaired in Surulere. It was like magic. It cost money. But guess what? At the convention is where I got the partner that donated hearing aid. The cost of one hearing aid can be as much as ₦1 million. And for me to get 40 from Rotarian Action Group for hearing, I had to join that action group and I got the benefit of it. So apart from what we did in screening the candidates, which cost money, which was the only part that we bore, the other cost of the hearing is part by the action group. So we should also try to apply for global grants for maternal health programs. Partnership. Every club can help save lives. We must collaborate. Today, 2 clubs collaborated. They can be next one. I want to make it bigger and bolder to attend to 110 traditional back attendance. And we need more people to be there. The more the merrier. And the bigger the program is going to be. So we must try to collaborate with both, even RMCH. For the Adeju is here. Partner with District 1860 in Germany. It's not only about Nigeria. Germany is involved. The next slide. And in cases where Rotary has been part of it, we have case studies and the outcome. The mobile clinic and midwife training in Uganda, the outcome led to 40% increase in skilled birth attendance. In India, the focus was to provide clean birth kits and maternal education. And the result is 60% drop in neonatal sepsis. In Haiti, post-earthquake, traditional birth attendants were trained and delivered emergency kits, and also health education was provided. And in Nigeria, where we are, what are we doing now? Next slide. There we go now. And that is the call to action. How to be involved in the advocacy. In 2022, Reproductive, Maternal and Child Health RMCH Action Group Nigeria was awarded a $2 million program of states POS. Now, when we ask for tell what is POS, they will tell you point of sale. It's not point of sale, it's programs of scale, please. It was a grant that was awarded by Rotary Foundation for the project titled Together for Healthy Families. And 4 states were the pilot states for this particular project. The target was to reduce maternal and child mortality by 25%. And the 4 states were Ekiti, Nasarawa, Gombe, and the Federal Capital Territory. But I can assure you that as we speak, the action group has made so much impact with the kind of facilities and equipment that have been put with using that global grants. That maternal and child mortality rate has dropped to 60%. Can you see the difference in the target and the achievement? That is the power of an action group. And it involves these 4 pilot states. But right as we speak, after 3 years, the foundation saw the impact and has chosen to now scale it to other states. But Rotarians are involved. There are, like, I'm the service coordinator. There are 6 states that I work with. And each state has its own state coordinator. PAG Femiloye is the one for Lagos State. We have for Ogun State, Said Abolore, past president. And we have others, they are all in medical lines. In the other 4 states in Southwest. So, what are we saying? That even in a different state where we are, we can do our own minor part of it to replicate what RMC Nigeria is doing in Nigeria. And that is where we want to go to ensure that we have more hands to do advocacy. If we are few, about maybe 3 months ago, no, 2 months, we sent out a flyer and we educated people on what this action group is about. And we included a link for people to join if you want to be part of it. We explain what the action group is meant for. You don't have to be a medical person. There are volunteers that are also involved in it. Rotaractors, even interactors, other community called non-Rotarians, anybody who is interested. And guess what? Over about 160 people have registered as members, and they are drawn from different parts. And that is not even enough. We are expecting that more people will join, so that anywhere you find yourself, the little you have had today, you can in your own club, in another month, another year is coming. It may not even be another year. Maybe another 2 months, we're going to put together at a project point. And you find that it's the point you want to emphasize, then do not hesitate to go and talk about it straight away, because we want to reduce this mortality rate as much as possible. If we don't do it in Nigeria, what SDG wants, that's 70 out of 100,000 life births cannot even occur. The next slide. I think that's the last slide. The next slide. So, are you interested in being a member? Oh, definitely. I'm sorry. It was eventually okay. I'm sorry. I think the last slide actually is not the correct one. So let me take it from this one. Call to action. Be involved in the advocacy. Join the Rotary Action Group for Maternal and Child Health using a link. And the link is provided in that last slide. Only that last slide is not on this place. But when I send the presentation, was going to be sent, and on all our Rotary platforms, I know PDG will make sure that happens, that everybody will read it. And for information, we have the following that we can ask questions from. Even if you want to know about this program of skills, the one in Nigeria, coincidentally, we have the country director in the house with us. It's Professor Adedola Kolufadeju, country director and national coordinator. We have past District Governor Mosunde Lose, Southwest Zone Coordinator, stroke membership chair, covering Lagos, Ogun, Oyo, Osun, Ondo, and the state. We have PhD Olufemi Loyede, Lagos State Coordinator and membership chair. And we have past President Said Abolore, Ogun State Coordinator and membership chair. Before I round off, let me charge all of us. We have said that it is not the job of only a person. It is not for only a Rotary Club. If you want a developed country, a country where nobody will be ignorant. In fact, today, those TBA, when they were there, I was asking Dr. Loyede, I said, you meant that these people could administer this, they could take high blood pressure, they could give injection. I was surprised. So if they could do that, what we need more is to make them more skilled and to let them know the do's and don'ts of make sure that we have maternal and life and child mortality reduced by avoiding things that will make it not to reduce. And by putting in place all those measures that will improve the quality of health of the mothers that will ultimately result in giving birth to very strong, healthy, and well-protected babies. Thank you for listening and have a lovely evening. Thank you.
Thank you very much, my PDG Obatune Lawson. Next, we need to save our time. I'd like to also recognize in our presence Veteran Past President Veteran Lara Akisoya. She's the Women in Rotary Coordinator, Women in Rotary Chairperson for Rotary 910. She'll be getting ready to give us a good message as time goes on. To lead us in discussion on general discussion is our own Rotarian Dr. Bat Ufegbuna, but he is not here presently. So I will humbly request our PDG as the National Coordinator for RMCH, referred Professor Fadeju to give us the good message and also to lead us in the general discussion. Especially
just a minute, my past president. There is one more presentation from our DGE, and I understand that respected Rotary and PG Jonathan was here to deliver a talk on our behalf. She's going to be talking briefly on what is the role of women and women voices when it gets to initiatives to reduce or improve their own health. So, if you don't mind, sir, let me just immediately bring on board our past life governor, Tony Atari, Triple T. Thank you so much.
So much.
I don't know if she's with us, but I could see her on
She's
the
here.
screen here.
She's
She's
there.
here. She's already sharing it, please.
Oh, okay.
Page Director was already sharing a slide, and we are ready to take her on. Thank you very much.
Hello, Rotarians. Good evening.
Good evening. We can hear you clearly,
Hello,
ma'am.
good evening.
Good evening. Good evening. Good
Okay.
evening.
Good
Can go
evening,
ahead.
fellow Rotarians. My past district governor, the PDG Motunde Losin, Rotarian Dr. Oluyede, and fellow Rotarians. I'm happy to be here. And hello.
We can hear you.
We are with you.
Hello.
We are with you.
Okay. I want the next slide to come up. I believe this is the paper I'm supposed to take anyway. Oh, yeah. I'm supposed to speak on women voices concerning maternal health.
Are you sure it's the paper, Sha?
Concerning maternal health. And I think the paper is the paper is with you. Hello. Maybe I should just.
Papa is not with me. Okay, it's with me, but I can pass straight to Otun.
Yes, it's here. It's on now.
Yes, it's good.
Okay, it's on now. Okay. I'm sorry. I was trying to see maybe I can send it, do it myself. I'm coming. Oh, please. Sorry.
You can speak to it now. We try to follow.
They will do it for you.
Okay, fine. Women voices on child and maternal health. Please, next slide. Good evening, fellow Rotarians. Yes. What are we talking about when we say women voices and maternal health? We are talking about the advocacy that prioritizes women's lived experiences, our perspectives, and participation in sharing health policies, services, and interventions affecting mothers and children. Why does women's voices matter? Because of first-hand experience. Women, especially mothers, directly experience pregnancy, childbirth, and children upbringing, giving them unique insights into the barriers and the preferred solutions. 2, better health outcomes. Evidence shows that when women are involved in decision-making, maternal and child deaths, so services improve. And that's a fact. Equity and rights. Centering women's voices in the instance helps address gender-based disparities and ensures healthcare is rights-based and culturally sensitive, most especially people that believe in traditional ways of doing things. Please, next slide. What are the common challenges from women's perspectives? Number 1, access to care. Distance to clinics, cost of services, and availability of skilled birth attendants. Quality of care, respectful treatment, informed consent. These are very important. We have some women that would rather prefer women to attend to them and not men. That's just an example. Informed consent and culturally appropriate care. Nutrition. Adequate maternal nutrition before, during pregnancy, and after pregnancy, and child feeding practices. This takes care of a lot of things for us. Our mental health, stress, emotional support, and postpartum depression. These are part of the challenges. Community support, role of partners, family members, community health workers, and women's groups, and policy inclusion. Ensuring women participate in local and national health decision-making. These are very important. When we are talking about women's voices, we are not talking about the patients alone, the pregnant women, the mothers. We are talking about all women that are in healthcare, even women who are in policy-making positions, to make sure that our voices are heard and decisions that matters, that concerns us, matters in the making. Next slide, please. Next slide. What happened?
So it's there. The slide is there.
Hello, are you hearing me?
Yes.
Okay. Okay. 3 ways women voices can be amplified by storytelling and testimonies. Sharing potential, personal birth and parenting experiences. You know, when you go to some clinics, maternal clinics, you see a lot of women there clapping, singing, but people telling them the stories of how they went through it. It matters a lot. Through media, podcasts, and forums. Those ones are forums. The clinic maternal programs that they do for pregnant women. Community dialogues, women-led community meetings with health officials. Women voices can be heard and can be amplified through that. Maternal health advocacy groups. We have women-driven organizations that lobby for improved health services. Through digital platforms, social media health campaigns, health research, including women as co-researchers in
Anyway, have we lost her?
It seems the problem is from us.
Yeah, she's not here. I can't see her here now. Oh, I think she's out. Let's hope that she's going to be able to join back.
Okay, let's pray that she's able to come back on board. Our slide is still open. Let's progress a bit while we are waiting for our return to conclude our presentation.
Let me quickly just share before maybe I'll share a little story. 1 minute. Okay, she's back.
Okay.
Hello? Hello?
Yes. Welcome back.
Welcome back. Hey, you.
Welcome back.
I'm so sorry. It's where I am. I'm so sorry about that. Like I was saying, health research, including women as co-researchers in maternal and child health studies. Please, next slide. What's wrong with the network here? Hello?
We are with you. We can hear you loud and clear.
Slide. Hello?
She's asking for the next slide.
Number 4, advocacy examples. We have what we call Mothers' Voices Initiatives. This is a program in Sub-Saharan Africa and South Asia that train women to speak at local health planning meetings. We have midwives and community health workers. They can serve as both caregivers and advocates for women needs. Next slide, please. Now, key recommendation: involve women at all levels, from the grassroots, traditional midwives, government health committees, to national policy boards. Listen without bias. Recognize the women's experiences, that women's experiences may challenge existing healthcare norms. C, invest in women's leadership, training and resources for women as health advocates. Very important. Integrate feedback mechanism, collect and act on women's feedback in health programs. All these are very, very important. I have only 10 minutes. That's why I quickly put all this together. And then please, next slide. Thank you very much. Thank you so much.
Thank you.
Thank you so much.
Mamiya. Sorry, I'm in the meeting. I'm coming. Thank you. I'm coming.
Thank you so much.
Thank you very much. Yes.
Okay. We're talking about the program of scale, the POS, before we took a detour to take this position. The 2021-2022 POS was awarded to Nigeria with the 80 Families Nigeria, a member-led program of skills and to improve access to quality health. The project was sponsored by District 1860, Germany, and this 910 then it's 910, now it's 911 and 912. This 9125, it's 9141, and it's 9142 Nigeria, as well as the RMCH. That program has gone into full scale and Nigeria has really benefited. The preparation for 2025-2026 program of scale has started in earnest, and we have in the house our own referred PDG, a Professor Fulvadeju, to throw more light on the program of scale that happened in the Kitty and how we can benefit 2025-2026 POS, and from there do more impact in Southwest Nigeria. President Fadeju will be leading this general discussion, at the same time giving us his good message. President Fadeju, please, you have the floor, sir. Thank you very much for coming on board.
Thank you very much, Otunolalekan. I have sat down patiently and listened to all these wonderful presentations by our past district governor, Omotunde Lawson, and also by my very good friend, Oloyede. And even the last one by Antonia Taiwo, a very good presentation. I appreciate all of you for this wonderful webinar. Let me thank the district governor of the district for bringing this about, and particularly our zone coordinator for the Southwest, past district governor, Omotunde Lawson, who is one of our most active zone coordinators in the country. Thank you very much for your engagement with reducing maternal and child mortality in the country. I would not like to repeat what has been said before. I will just give a few clarifications here and there. First of all, the program of scale is to reduce maternal mortality by 25% in 4 locations: Gombe, Nasarawa, Ekiti, and FCT. The program of scale is awarded to Nigeria, not to any country, and it is a Nigerian program. We have technical partners in Germany, and we have a great support from the Rotary Foundation in Evanston. The key issues have been discussed: causes of maternal mortality, postpartum hemorrhage, eclampsia, sepsis, which is infection, and abortions. These are the main causes. And of course, you have the risky pregnancies. Pregnancies that are too early in life, too late, too many, and too close. And you have what we call these 3 delays, which has to do with earth-seeking behavior. The delay at home to make a decision to access facility for delivery, a delay on the road to the facility itself, transportation, available fund, and other impediments that can stop a pregnant woman from accessing a facility nearest to her, distance, for example. And then you have the delay in the facility itself, whether there are facilities, whether there are beds, whether there are doctors, whether there are attendants, skilled attendants, and so on and so forth. So this is the condition. So because of this myriad of problems, 70% of births are taking place at home, where there is no support. And therefore, one of the key issues of the program of scale is to move women from delivering at home to delivering in the facilities. Okay, when they are pregnant, they should seek antenatal care. When they deliver, they must seek postnatal care. This is one aspect of the program of scale. Because of this and because of our work, a lot of women have started delivering in the facilities. Many states are already upgrading their primary care centers. A lot of equipments are being supplied by Rotary and by the state governments involved in the program of scale. And we have done a lot of capacity building, community engagement through community dialogue. We have a lot of outreaches, medical outreaches that can access places that are hard to reach. These are the key things that we are doing at the moment. And we have preventive measures. The maternal and perinatal death surveillance and response is a policy of the federal government, but Rotary has provided an electronic platform that allows the audit of maternal death in the country. So maternal death in Nigeria is now a reportable condition, just like you report cholera or you report meningitis. So also maternal death is reported along the health information system in the country. And when I listened to all the talks, I saw a lot of statistics here and there. We don't really have concrete statistics in our country because most of these statistics are estimates. That is why the electronic platform seeks to establish data collection, not only from facilities, from primary care centers, from tertiary institutions, secondary institutions, and also from the community, including the private practitioners. When we are able to do that and put everything on the electronic platform, we then get a concrete figure of what the maternal death in Nigeria is like. But as it is today, we will have to satisfy ourselves by using the estimates. The federal government accepted estimate is 512 deaths for every 100,000 live births. Now, this is misleading because in the south of Nigeria, it's below 200 per 100,000 live births. But when you go to the far north, like Sokoto, Borno, Yobe, and so on, you can get as much as 1,500 deaths per 100,000 live births. So it's an average figure. If WHO gives their figure, it will be 812 and so on and so forth. Everybody gives their own figure. But we are going to get a time in Nigeria where we are going to get real evidence, real time data that will show us the correct figure. So at the moment, the key activities, advocacy has been mentioned, community dialogue has been mentioned, capacity building has been mentioned of medical and paramedical staff, including traditional birth attendants and also including community health extension workers. We train journalists to be able to report and bring to the notice of people information about the maternal death in the country, and also emergency maternal and child care activities. For postpartum hemorrhage, we use the anti-gamete shock to prevent the bleeding, at least until the woman gets attention into the hospital. Misoprostol is used to prevent eclampsia. That is what has been said as high blood pressure. And of course, antibiotics, all kinds are being given to prevent sepsis. Abortion is prevented by advocacy, by counseling, mostly by counseling, which is a major part of our work. Now we are moving into what we call community MPCDSR. Because I said a major part of deliveries are taking place at home, in the community. That's in the house. And because of that, we do not have figures from home deliveries until Rotary came in and started community MPCDSR, which is a way of assessing maternal death at home in the community, which has to do with verbal autopsy, determining the cause of death, and data being transmitted to the local government and then to the state and to the federal government. So we have a structure in the POS that collects data in the tertiary hospitals, secondary hospitals, primary care centers, and in the homes in the community. The only aspect remaining to get a national figure is the private practice, because death do occur in private practitioner. But although before death occurs in the private practitioner's hospital, they are always transferred to the secondary or tertiary hospital. So we can say that those four major areas that I've mentioned are the areas where maternal data will be coming from. So I will think that my zone coordinator will make available time for me in future to discuss program of scale in more detail in order to save time. I also want to thank her for mobilizing Rotarians to join the RMCH. It's a very important thing to do. It's RMCH that gave Ogun, Lagos, and Oyo State the program on malaria. And before that, maternal and child death project being led by our past district governor, Nijiraji, is all through RMCH. And a lot of mosquito nets and bath kits and vitamins obtained, which we share all over the country. And I'm sure Lagos has also shared from some of these materials, and they will continue to share in these materials. So what is happening in Ekiti State is happening in other 4 centers in the country, okay? And it's the same thing, it's uniform. And now we are scaling. Technically, the program of scale will end at the end of this year, but we have been given until April to conclude. That means that we are going to scale to other states in the country and other local governments. Those local governments and states have already been selected, and we have the benefit of a donation from Sir Emeka Ofo, which will assist the Rotary Foundation to scale the POS, we call it POS2 MCH. So it's a win-win situation for maternal and child health in the country. And we also want to thank the zone coordinator for promoting the membership of RMCH. That is a very important aspect. She has given a good example. If you are a member of the RMCH, it's better, it's an easy way to get support for any matter, even ordinary community dialogue. If you want to do community dialogue in 4 local governments in Lagos State, for example, in the primary health care centers, you can select 3 or 4 health care centers in each local government and do community dialogue. We give you the prototype. If you want to do outreach, medical outreach, which you do, you want to do home visits, which we also do. If you want to do capacity building, we have the capacity to support clubs and districts in making sure that they get involved in this program. And that's why we have a network of past district governors throughout the country, of which Omotunde Lawson is one in the Southwest. All the zones of the country have a past district governor as the coordinator, and all the states also have a state representative. So you can see that the structure is there. It's left for us Rotarians to key in, clubs and districts to key in to benefit from this very important development and engagement in our country. So having said that, let me just allow you to take questions from the speakers, and if there's any clarification that you want me to do, please, I will be able to do it. But as I've said, the speakers have done very well. The program is running very well in the southwest of Nigeria. Lagos is a prime area where development has taken place and maternal mortality has been reduced. As I speak, after 1.5 years, we were able to reduce maternal mortality by 20% where we are working. And we hope that by the time we finish, we will surpass the 25% target. Home visit was supposed to be 5,000. As I speak to you, we have visited more than 20,000 homes in the country, and it is still growing. On that note, I want to thank you one more time, and I wish you well. I'm here. I'm available until the meeting finishes to answer any questions that you may have. On any of these topics, the speakers also are here. Questions can be directed to them directly. So if we can have your hands raised up on this discussion time to hear either question, clarifications, or comments. Briefly, let's make it very brief so that many people will have opportunity to talk. Thank you very much.
Thank you, Prof. With really much thank you, Sally, for your time and for your leadership position. Next, I would like to recognize the presence in our midst of PDG Remy Bello, who has joined the webinar. PDG Remy Bello, you are welcome, sir. Thank you very much for coming on board. Next, I would like to just give 1 minute to the President for Rotary Club of Maryland, Veteran Joyce Mary Sheyi, to speak for 1 minute. Good message before we will now take question and answer. Veteran Joyce Mary Sheyi, you have the floor for 1 minute.
Good afternoon, my fellow motivated Rotarians. I'm actually at work, but I just want to use this opportunity to thank the organizers of this program and our custodiary. We thank you for taking charge always, to Ewututu, our DGE, and other notable Rotarians. I say thank you, because this is a very crucial topic. You know, when I saw the figure that Nigeria is #1 globally, it saddens my heart. And I'll take this back to my club. Whether it's a month of July or not, you have to do more to support this cause. Once again, thank you all for putting this program together.
Thank you very much, my president, for speaking briefly. May I also invite our PDG Remy Bello to just give us a word. PDG Remy Bello, please, you have the floor for 1 minute, sir. It's still in the house. It's still in the house.
Oh, he's muted, though.
He's muted. Please, Secretariat, Elizabeth, please unmute our own PDG
Is it
revenue.
on, sir? Hello.
Yes, we can
You
hear
have the
you.
floor, sir. We can hear you clearly now.
Oh.
We
Hello.
can hear you now.
Are you
we
hearing
have
me?
the sir.
Yeah. Yeah. Thank you very much. I want to appreciate the organizers of this webinar, in particular our own district governor and Omotunde Losin, the Southwest representative of the program. I am very pleased that we are winning. The objective is being achieved. I congratulate the initiator. I recognize you, sir. God bless you, sir, for the effort. Yes, I think we are getting somewhere. We'll get there. The objective of program of scale, I believe, is being achieved with what we've heard from PDG Lufadeju now, that the program is being extended to other parts of the country. Sooner or later, maternal and child challenge will be brought to a very minimal level. So Rotary is winning. Rotarians are winning. Thank you very much for this webinar. It's a further eye opener to what we have known before. Thank you and God bless you all.
Thank you very much. It's like I can say hand up. One hand is up for question. Okay. Can we? We like to, we employ you to please. We can give the floor to the Chairman for Disease Prevention and Treatment with PAG Todoede to please have the floor. Todoede, you have the floor.
Yes, thank you so much, my past President Chairman. I just quickly seize the opportunity not to really make us realize that when we invited our speakers, it's simply because we know the caliber of people they are and the kind of thing they are bringing to fore. I'm particularly happy that the national coordinator of RMCH was able to give us a very brief update, and then to follow it up. I'll be very glad if that particular program of scale ongoing would actually move to Lagos more robustly. I can tell you that, just like my PDG said, this morning, what we had was an eye-opener. It was training of TBAs. I've now come to realize from the paper I've been presented that these TBAs, we cannot bypass them. We need to create a special attention for them under this POS, even if not in Lagos, wherever they are now. Because the bulk of the women that are going to have deliveries, pregnancies, and die, most of them will pass through the TBAs. So before they even get to where we give them anti-shock garments, where they will take some measures, where they will utilize some of those equipment and so on. They need to have been seen by those who will manage them fairly well, so that by the time they get to those places, they will not be as bad as they are. And I agree with my coordinator that most of this that occurs in that rural area. So that's why I'm craving his daughter that we'll be speaking to him through my Southwest coordinator, that special attention be always given to Lagos like in other spheres of our national life. And we hopefully, by the time we want to do the next of this program we had this morning, it will be on a larger scale where we are going to have TBS from virtually all local governments in Lagos State. Now, the subject we have today really is just to discussion this evening, just to tell us how bad it is in Lagos State and the country, and happy that it's pointed out very clearly. But the second major reason is to drum support and attention to our members to join RMCH. That's the second objective. And I'll be very glad if all on this platform would enlist as members of RMCH, volunteers in RMCH, ROG. The form will be sent out. There is a Google form that we use. So you can reach out to my PDG, myself, like she have said, for Lagos State, and others for those outside Lagos State, in other states, you know, so that we have a robust membership that can drive home, that can drive the project, I mean, the projects that is being coordinated by RMCH and also other clubs and districts. And lastly, the third reason why we brought this webinar up, is to let women know that they have a voice as related to their own health. And I will give a very short narration that we expect others to contribute to. I just saw a young lady who just had a baby. She was about 17 years. You won't believe it. About 17 years. Very young lady who should still be in school. And because of counseling her, I told her, since we want to go back to school, it is nice that we place you on a form of family planning so that it can give you enough time, go back, do what you want to do, and then come back into childbearing. But I have not walked just a few kilometers when a man approached me and said, doctor. I looked back, hello, how are you? So I said, ẹ̀yin mo fẹ́ rí. Okay. Mo ní ṣé ẹ̀yin lẹ rí arábìnrin, wọ́n lẹ́yìn lẹ rí arábìnrin kan, ìyàwó mi lókè ń bẹ̀ yẹn. Mo ní èmi náà ni. Ṣé ẹ jọ̀ọ́, ṣé ẹ̀yin lẹ sọ fún mi pé ó máa ṣe family planning? Mo ní èmi náà ni mo sọ fún un nítorí ó ní ọmọ. Before I could say anything more, he said, ẹ dúró. The man was so bold. I said, ẹ dúró. Báwo lẹ ṣe máa sọ fún ìyàwó mi kó máa ṣe family planning? Right? Elderly man, child of 17 years. And he now said something in Ìlú Èkìtì. He said, ẹ̀yin wò dáadáa ni, rí pọ́nmọ́ ń bẹ lára rẹ̀ ni, ẹ fẹ́ pọ́nmọ́ lára ni. Ọmọ ẹ̀tọ́ ni wọ́n ń bọ́ lára rẹ̀, ó ṣe tó bá yẹn táwa ti rí, ẹ̀yin ní kọ́ lọ my family planning. The lady obviously does not have, and he warned me that I shouldn't try that. I don't know what the kind of boldness he had to confront me, even in the hospital premises, right? But that is just an example of how bad or how low voices of women can be in matters that relates to them. I don't know if there are comments or examples that anybody could give in this instance too, but that is just one. And that's why we are asking our DG and PhD to please address that particular instance. And I'm sure they also did well in that response. Thank you so much for now.
Thank you very much for this narrative. It's so pathetic, but it's so pathetic. I think we will get there soonest. We have lawmakers in the house and so on and so forth that can help us to push this case further than this platform. Can we take questions from the participants in the house before we now invite the women in Rotary chairman to give the vote of thanks? Questions from the house by indication of raising of hand. Questions?
Let me quickly make a clarification. On the program of scale, the traditional birth attendants are used essentially for referrals. We do not encourage them to take deliveries at home for one reason. You do not know how a pregnancy is going to be presented. There is a story in Gombe of a woman who was pregnant with twins at home. And the TBA was able to deliver the baby, the first one, naturally. And then the second one was coming as a bridge, not head first, sideways. It was very difficult for the woman to deliver it. In a situation like that, if there is no, our project community health extension workers who told them that they have to go to the hospital immediately, the TBA may try to continue to deliver that baby and it will be unsuccessful because they do not have the skill to rotate a fetus. To rotate a fetus to the delivery point. So they had to rush the lady to the hospital, and there, the doctor, within 5 minutes, they just rotated the fetus, and she was able to deliver naturally. And the two children are doing very well. The mother is doing very well. It could easily result to death. She could start bleeding. If it is prolonged labor, she can start bleeding and she can lose her life. So we encourage TBAs to refer and to counsel and to support babies who have been delivered to go for immunization, to support them to attend postnatal clinic after delivery, and to support them to look after their health in terms of nutrition and clean water use for children and so on and so forth. They have a lot of role to play, but we do not think that one of such role is to take delivery at home at this point in time. Thank you very much.
Yeah, thank you so much, sir. But permit me to also chip in this particular point. Now, in Lagos State, it's a bit peculiar in the sense that the government has come to realize that they can't but work with them. And that is why the state government created even a board for Lagos, for traditional birth attendants in Lagos State, and also said these people must be given strict guidelines, monitoring, some form of education, training, emphasizing the fact that they must know their limits. And that was stressed very well this morning. That is peculiar with Lagos State. Maybe not other states. I cannot say that. And it's just to also remind us, sir, that in some part of Africa, even cesarean section, you won't believe it, that are being done by non-physicians under certain conditions, because those people have come to realize that, look, if we don't do that, death or shortage of manpower to handle them, just like the TBS in this part of the world, in this part of the country now, most of these people deliver in that places. And whether we like it or not, sir, because of their culture and so on, they will still visit them. So we now felt that, look, if they will still go there until we're able to until we're able to achieve a reversal through the effort of peers and others like that, that we must still bring them closer and tell them, like I said this morning, anybody that is first pregnancy, anybody that is twins, anybody that has leg swelling with protein, anybody that has previous cesarean section, anybody that has this, has no business in your place at all. And if we find them there, you will be severely penalized. Because we do know again that economic factors makes the women, those families, to go there, and also make them to want to accept them. So I think, sir, that we might have to find a middle point where, just like we are trying to incentivize them, refining them as quickly as possible, but we are also, at the same time, punishing them if they go beyond the limit for which they must go, if accepted by the state, rather than completely shut them out, because the bulk of these patients are from there, and before the referrals get to where they are going, they would actually have, the case would have been so complicated. But like I said, sir, that is peculiarity of Lagos State, and maybe some, but we keep discussing.
Dr. Loyede, we can
Yes,
discuss
sir.
this. We can discuss this later one-on-one.
Yes, sir.
Because of time.
Yes, sir.
But what applies in Lagos also applies in other parts of the country.
Okay,
They
sir.
have been. We have highly trained TBAs. But
Yes,
the
sir.
point usually is, where do you draw the line? Where do you draw the line? Where do you make a decision? Enough is enough. I have to stop now and take this woman to the hospital. Because she's going to be expecting to be paid some money, little money.
Yes.
That means nothing. And
Yeah.
because of this incentive, she continues to press without knowing where to. So they are not being shut out completely. They are being assigned a different role that does not have necessarily to do with childbearing in the home. There are so many things. There are so many things doctors do immediately after the delivery of a child that makes child survive. That's what is called make a child live.
Mm.
You know, if a
Help the baby breathe.
if a TBA delivers a baby and they don't know what to do, they will think that the baby is dead and they will go and bury the baby. But resuscitation of a fetus can take up to 45 minutes. using different techniques, slapping the baby, holding the baby upside down, shaking it and all that, up to 45 minutes. The TBAs do not have that kind of time. They don't have that kind of training to help baby to breathe. So a lot of babies that have been born that have been buried when they are still potentially alive. Many things. So let's discuss this at another time, so that we don't take people's time unnecessarily.
Yes, sir.
They
Yes,
are
sir.
not being sought out. We are assigning to them a role that we know we are sure that they can take, and it will be safe for all concerned.
All for everybody.
Yeah.
Thank you, sir.
Thank you.
Thank you very much, Prof.
Yeah, thank you very much.
For the next 1 minute, we want to give the floor to those that want to ask questions. If there is none, we can quickly end the webinar because of our time. See none, may I invite the chairman for Women in Rotary, chairperson of Women in Rotary, past President Raki Sonia, to please give us a vote of thanks for today's webinar. Lieutenant Lera Akisoya, you have the floor. Lieutenant Lera Akisoya, you have the floor for vote of thanks.
As we wait for her, I just passed information that she's talking, but I think she muted herself. She didn't know. I can see her here saying something. She is the chairman of Women in Rotary and one of our regular supporters for our regular collaborators.
She's up now.
Good evening, the moderator. I want to thank God for this wonderful experience that we all are having this evening. I myself, as a retired midwife and registered nurse, I have gained a lot from our Professor Emmanuel Lufadeju. You know, it rekindles what we were taught in school as midwives. And I know that Rotary is doing a lot because this month is Maternal and Child Health Month. And I know a lot of Rotarians clubs have gone round to do one donation or the other. Having said that, I want to seize this opportunity to say a very, very big thank you to all our speakers today, especially Professor Emmanuel Lufadeju for your time, the DG in absentia, the DGN, and our own Kosheleri, Ayabamotunde Losin, our PDG. Thank you so much. And like it has been said earlier on, I, as a chair for Women in Rotary would like our members to please, once the Google form pops up, we should please register and be part of this laudable project. It goes a long way to prevent maternal deaths. A lot of things are happening in and around us. So we should be partakers of this laudable project. Once again, I want to say a very big thank you to the chairman, Disease Prevention and Treatment, PhD Dr. Femi Oloyede. Thank you so much. I'm sure we're going to have more of this collaboration to be done in the future. You know, every month we will have different types of programs on health to discuss with our Rotarian members. And I want to use this opportunity again to say, anytime we're having this kind of webinar, we should invite our friends, our families to be part of it. No knowledge is lost. Once again, I want to say very big thank you. And I pray that we all have a very wonderful night. Thank you very much. God bless you all.
To all our participants tonight for the webinar, we want to thank you all for coming on board. We want to thank you to Femi Oloyede. We want to thank Professor Fadeju. We want to thank our own Kosheleri, PDG Omotunde Lawson. We want to thank PAG Tune Tayo. We want to thank our own PDG Remy Bello for coming on board. the United President Club of E-Club of Maryland, you are welcome. The President Club of Otutu, Honorable Stephen Ogundikpe, you're welcome. On behalf of the organizers, I would like to tell everybody, have a pleasant night and good night rest. We leave the platform open for the next few minutes for people to network and to say one or two things. Thank you very much for coming on board.
And to have their refreshments. And to have their refreshments.
That was the virtual refreshments.
Thank you so much. We are really very glad.
Very much.
Thank you so much, my PhD, Olufemi Oloyede. This is quite interesting and I've learned a lot. And I'll be available to join the RMCH by God's grace. Thank you, sir.
Oh, that's great. Thank you so much. We are very happy with that. Thank you so much. But the young lady that I narrated her story, you didn't tell me what to tell her. She wants family planning, but the husband came to accost me that how dare me say that.
My papi, please, I fear for you. Don't go there again.
I shouldn't go. Okay.
Stay away from the woman, sir.
Okay.
Stay away, sir.
Okay. Thank you so
You're
much.
very important to us.
Yeah. Cheers. Have a pleasant evening.
My PhD Oloyede.
Yes. Thank you. Tony Ataiwo, thank you so much, man. At short notice.
Hello, sir. PhD Oloyede.
Yes, please.
Good evening, sir.
Good evening, man.
My name is Rotarian Dr. Beatrice Ebong. A member of Rotary Club of Lagos West and also committee member of Women in Rotary. I love the story you told, but those that did not understand Yoruba may not really get
Okay. Apologies.
I understand the Yoruba, but I know that there are some people.
I actually just wanted to drive home how he said it. So, exactly the way he said it. The only person that would have understood the last part would have been my respected district governor, PDG Remi Bello. He understands Yoruba very deeply. The man said, so Romola already.
I understand everything you said. I appreciate this program and I thank all the coordinators. And by the grace of God, I will also join the group. Thank you.
Membership. Thank you so much. We appreciate it. PDG, thank you so much for coming. Remi Bello.
Having said that, please, it's important that we should just go around and not go around like it has been advised that we should join some groups to make sure that we talk to people who have Omolara Pupo, so that if you have plenty children in your body, that doesn't mean that you should just be giving birth anyhow. There should be family planning, like Dr. Oloyede mentioned, and well, I don't know, people that are full. I mean, I don't want to say it in Yoruba. People that are full in their belly, they're trying to pull in their tummy, and those who are hungry are trying to push out their tummy. I don't know, when you don't even have money to take care of 2 children, you are having 5, 6 children and putting a lot of pressure on other people. I think the issue of family planning has to be, we have to bring it to fore and advise our women on family planning. It's very, very important. Olashade, how are you? Thank you, our members from Women in Rotary and Dr. Betty Gogo, all the women on board. Thank you very much for being part of this program. You guys are awesome. God bless you all.